All right, next is Dr. Harry Sequeira. He's from my institution, Our Lady of the Lake Cancer Institute, the Heme Malignancy Program. Dr. Sequeira's clinic is dedicated for AML and myeloid malignancies in general. Excuse me. He's part of the ramp-up effort to start allogeneic stem cell transplant at the lake that we're hoping to start very soon. Today, he's going to talk to us about redefining frontline AML therapy, the journey from 7+3 to Aza-Ven. Harry.
Is it a clicker or oh, no, the clicker plus and then back. You see? Yep. Front and back.
Okay.
And then
Well, I'm not that tall, so let me put it here. Good morning. My name is Harry Sequeira. Thank you for the opportunity to present, and today I will talk to you about redefining the front line for AML. I think it's always very important before we start talking about clinical trial to place everything into perspective, to differentiate the patients we see in the clinical trials to the usual patients we see in the clinic. So just as a beginner, we're going to see the latest year data, and we're going to start with the average age of diagnosis of the AML. So AML, as we know, it's a diagnosis of elderly patients with an average age of diagnosis of 69. And more than 60% of the patients actually are diagnosed after 65 years of age. Not surprisingly, the age of death is actually a little above that, which is 74. And this also translates that even though patients still have access to treatment for AML, as they get older, the overall survival is compromised. And while more than 60% of the patients are diagnosed after 65, more than 75% of the deaths come from the same group age. Now, this is the 5-year-old survival for patients with AML, and this starts in the 1970s, where actually the clinical trials from 7 and 3 started, and this is all the measure points until 2017. So it took us roughly 5 decades to go from 5.5% of overall survival at 5 years to roughly 33%. Now that we got the basics out of the way, let's just start walking down the path of 7 and 3 and all the AML therapies, going through targeted therapies and bone marrow transplant. Everything started with Yats in this group in 1917. And these are 2 different clinical trials. We will talk first about the one in the left first. So this was the first clinical trial that proved that 7 and 3 was efficacious. So this was composed of 8 groups of 8 patients that were not treated before and patients that were relapse refractory. And for here we can see that the response rate for patients that were never treated before was significantly better. So 5 out of the 8 patients that were not treated achieved complete remission. And 2 of the patients that were treated, only 20%, achieved complete remissions if they received therapy before. Now, but where did 7 and 3 come from? What was the preceding chemotherapy regimen before that? That's the right picture that we have. So that's CAGLA 7421, and this was the preceding chemo backbone that we had before 7 and 3, and actually was 5 and 2. And the idea before we switching from 5 and 2 to 7 and 3 is that 5 and 2 was not allowing the patients to be enough myelosuppressed. So they needed more chemotherapy to achieve more myelosuppression, and the idea that will improve the complete remission rates for the patients. And it was true. So if we see the curve with the 5 and 2 patients, there was only 33% complete remission rate compared to 56 with 7 and 3. And more than that, after treating more than 1,500 patients within the CAGLA group, this was the first time that they recorded a 3-year overall survival to be 15%. They also noticed that the long-term overall survival was better for those patients that achieved complete remission early. That was more than double at 35%. With that information in mind, the first randomized clinical trial happened. And these have 3 comparison arms. They use 45 daunorubicin with 100 cytarabine, 30 of daunorubicin, and adriamycin 30. And kind of like what we use it today, patients that responded moved to maintenance therapy, but the maintenance therapy back in the 70s was significantly different, and they were followed along that. Now, what was the information available at the time of the creation of this randomized trial? So this table summarizes the highest complete remission rates and single institution data in the 70s. So we can see from the Yates, at this point, they had 2 more patients with a complete remission of 63%. Then down to daunorubicin with food and the group that had a slightly higher complete remission rate with slightly higher dose of daunorubicin, and Reese et al. That had a whopping 85% complete remission with a little bit of more intensification with thioguanine as part of their backbone of chemotherapy. So how did this change translate into response rate? It's interesting that already in the 1970s, we had 85% remission rate. But as you can see, this was not something that everybody could have the benefit to achieve. This was only for younger patients. And as the age progressively increased, the complete remission progressively decreased. So it went from 85, 76, 65, 36, and as low as 21, only if you were more than 70 years of age. How can we explain that? Well, we just need to move to the next line, and it's the death during the induction rate. Patients that received the same amount of chemotherapy as they were aging, they were dying more from the chemotherapy, which precluded them to achieve complete remission. And here, already 50 years ago, we knew that the toxicity could compromise the responses that we have from our patients. And as a test of tolerability, we can just see the next age group, which is 7 and 3 with a smaller dose of daunorubicin, which is 30. This time, I would like you to pay attention to the 60 to 69 group and the 70 group. And it's paradoxical that actually with less chemotherapy, we achieve higher rates of complete remission here. And it was 36 compared to 49, and more than double, 21 compared to 43 in the older age group. And this is just a test that we knew already from the 70s that more chemotherapy could compromise the response rate. Now, let's talk about a little more of the complications, and this is comparing the 45 dose in a set of 60 years of age, more and below 60 years of age. And you could see already that patients that were above 60 were twice more than likely to get infections, significantly more likely to get hemorrhages, 3 times more likely to get liver disease, more than twice likely to get renal disease, and so forth. So older patients with the same regimen had significantly more complications, and this was compromising the rate of response for these patients. You could also wonder, why didn't we talk about adriamycin? This was the third arm in this group. And it's actually because although adriamycin achieved a significant good amount of complete remissions, that was compromised with toxicity. There was a big group that had enterocolitis, necrotizing enterocolitis, and patients unfortunately died from that complication. So what did we learn from these clinical trials? As you age, you're less likely to achieve complete remission, you're more likely to get complications, and you're more likely to die during the induction. Now, let's move to 2000s. So now in the 2000s, we're going to start with venetoclax as single agent. And this was a very important clinical trial, a phase 2 single-arm clinical trial that took 32 patients for venetoclax. It was mainly comprised of patients that were relapse refractory, so 30 out of the 32 patients were relapse refractory, and only 2 patients were newly diagnosed. In this trial, the dose of venetoclax was different to what we use currently. The dose here was 800 milligrams on every day. And for those patients that did not respond, were allowed to increase to 1,200. And for those patients that did respond, where they were losing their response, they were also allowed to go to 1,200 milligrams of venetoclax. We could see how many lines of therapy. There was heavily pretreated patient with 41% of the patients at least having 3 lines or more, which could either be 7-3, hypomethylating, and even transplants. And on the right, we can see the cytogenetic footprint of the patients that were in this trial. IDH was a little overexpressed compared to the usual distribution in AML, but you could see down that there were still some patients with complex cytogenetics. So what was the response in this clinical trial? We made two tables here. One is the overall response rate, and the other one next to it is the IDH2 mutant and IDH in general patients. Because it's important to know that majority of the single agent responses came from the IDH2 mutant patients. Actually, the only 2 patients that achieved complete remission were IDH2 mutant, and 2 out of the 4 that achieved CRI were IDH2 mutant as well. So the overall response rate for IDH2 mutant were 50% compared to a general population of all comers of 38%. And if you're not IDH2 mutant, you were more likely to get a stable disease rather than have a complete remission with single agent. To further characterize the responders, these are the complete remissions on the top and the stable disease on the bottom. And you could see that the average exposure to venetoclax was somewhere between 3 or 8 months in actually both of the groups. But the main difference is that the responders usually have more abnormal cytogenetics on top of the IDH2 mutation. And stable disease were more complex karyotypes, 70q deletions. At the end of this clinical trial, there was already preclinical data suggesting there was going to be synergy with azacitidine and venetoclax. So the first patients were starting to enroll with a phase 1b trial to prove the concept of Aza-Ven. Once that information was available, the confirmatory phase 3 trial, VIALE-A, came to be, which randomized mainly patients that were above 75 years of age with equal performance status between 0 and 2, or younger patients that could have equal performance status up to 3. And what we're going to do now is we're going to go from the oldest patients to middle age to the younger patients, and we're going to analyze the data in every of those clinical trials. So this is the latest update for the Viali-A trial, and after 40 months of follow-up, you could see that there was a significant difference for all comers for patients that have venetoclax combined with azacitidine. To look a little bit more down the differentiation, the median overall survival in the venetoclax group was 14.7 for all comers compared to 9.6 months. At 2 years, the overall survival rate was 37 compared to 16, so more than double. And actually, the CR/CR rate actually also more than double, 66.8 compared to 29. But let's go back to the IDH2 mutant. So what happened in the IDH2 mutant patient? How much of extra effect did the combination have? And actually, if we take both IDH1 and 2, the response was more than triple in all comers. And if we separated, IDH1 actually had more than 5 times better response when there was a combination of azacitidine and venetoclax. And while the numeric number was larger in the IDH2, it was because IDH2 itself has a better prognosis and a higher response rate with any treatment. And it was just a little bit more than double the response rate with combination of azacitidine and venetoclax. Moving down the age group, now we go for CPX-351. And just as a little refresher, CPX at the time came from a randomized phase 3 clinical trial that compares 7 and 3 versus CPX in patients that were between 60 and 79 years of age, so 15 years younger, that were high-risk AML and that had the history of either MDS or myelo-related chemotherapy before they were randomized to this trial. And CPX proved to be better than 7 and 3 in this group. Now, this is real-world data that preceded the randomized trials we're going to see later, compared to azacitidine and venetoclax. And already in real-world data, before we were able to create these randomized trials, we saw that there was a comparable results. So the 30 and 60-day mortality were the same. The overall survival was not significantly different, but we saw that we were able to achieve the same results with less infections, less fetal neutropenia, and significantly less hospital stay. Going down the line, let's go to younger patients, now less than 60 years of age. And before we see the clinical trial, I just want to explain a little bit more about the prompt of this picture. It was interesting that most of the tables, before I came to this, I created artificial intelligence to create the tables itself. And the only prompt I set for this picture is create a young patient that has the choice to walk 2 paths. One will be HMA and Ven, and one will be intensive chemotherapy. I didn't say anything else. And it was the artificial intelligence itself that decided that the cloudy, rainy path was going to be intensive chemotherapy, and the HMA and Ven was going to be the sunny path for that patient. Interesting. Now, let's see if that's true. So this data comes from Asia. And this was one of the first randomized clinical trials that compared intensive chemotherapy versus HMA and Ven. And this time it was not azacitidine, it was azacitidine. The randomization was 1-to-1, and you could either be in the azacitidine arm, which followed the standard usage. You give 20 per milligram square, the usual use of venetoclax, and you achieve partial remission. You were allowed to reinduce with the same regimen. Same in the intensive chemotherapy arm was idarubicin with cytarabine. The difference here in this Asian clinical trial is that regardless if you're azacitidine venetoclax or 7 and 3, both groups were consolidated with cytarabine. And that's different how we practice here. So important data to review, but it's not exactly how we do it here. Both groups were allowed to move to allo transplant depending on the risk, and they were treated until progression, toxicity, or withdrawal. Now let's see the results. Here, in even younger patients, we saw that the cytarabine and venetoclax had higher response rate, composite response rate, higher CRs, higher CRIs, deeper MRD negativity rate, and an overall response rate that was comparable. If we look a little bit deeper, in the subgroup analysis, which is, of course, only hypothesis generator, but you could see here, even within the young group, there was a division at 40 years of age. So after 40 years of age, already there was a statistical significance favoring the cytarabine venetoclax over intensive chemotherapy. And probably to the investigators' surprise, one of the most treatable AMLs, which is core binding factor, only had a 44% complete remission rate compared to 88%, and this was actually favoring intensive chemotherapy. We move forward then down the line to the box. And I included all these mutations in the box. Some of them were statistical significant, some of them were not. But you could see as a whole, there was a numerical trend to favor venetoclax and Aza-Ven as a group compared to intensive chemotherapy. And with that information, let's review what were the last ASH updates in 2025. So this is the paradigm trial. The paradigm trial took all this information that we reviewed before and created a randomized phase 2 trial that had a 1-to-1 randomization between azacitidine and venetoclax and 7+3 or CPX. That's the intensive chemotherapy arm. Like we saw before, core binding factor was not allowed, PML-RARA was not allowed, FI3 and NPM1 mutated patients were only allowed if they were more than 60 years of age. BCR-ABL and mixed phenotypes were not allowed. But other than that, any 18-year-old or more that was eligible for intensive chemotherapy and had an untreatable AML was allowed to go into the trial. Both of the arms followed the usual way that we manage this, which is for day 14 bone marrow, partial remission can get a reinduction, response can go to either consolidation or transplant, and the same usual for azacitidine and venetoclax. Now, let's review here the baseline characteristics. And if you remember, the SEER data showed that the average age of diagnosis was 65, so this group resembles a lot the patient that we're gonna see in our clinic compared to usual, the Aza-Ven that was younger patients. There was a couple of things that were interesting here, that there was a numerical difference between the favorable and the adverse groups in intensive chemotherapy in Aza-Ven. There was slightly more favorable group in the patients in the favorable group with azacitidine and venetoclax, which was comprised of IDH and NPM1 mutated patients. And as we know, those mutations are very sensitive to venetoclax. And roughly 50% of patients more of TP53 mutation in the intensive chemotherapy arm, which is historically we know that is chemo-resistant mutations. With that in mind, what was the healthcare utilization? So patients that were in the azacitidine venetoclax arm were less likely to stay in the hospital, actually less than half. Within the 6 months was 41 days compared to 58, and 0 patients were admitted into the ICU with the Aza and Ven compared to 10%. What was the response rate? So we had roughly a composite response rate in the Aza-Ven arm of 81% and 55% in the intensive chemotherapy. But more important here is that roughly 3 times more patients were refractory to this disease if they received intensive chemotherapy compared to Aza and Ven. And this is the summary of the results. So better composite remission rate, non-difference in the 30-day mortality statistically speaking. There was a significant statistical difference between EFS, 15 versus 6. There's no statistical significant difference in overall survival. And there were more than double of the patients that were either IDH2 or NPM1 mutated in the HMA-Ven compared to the intensive chemotherapy. And there were more TP53 in the intensive chemotherapy arm, and more patients moved to transplanted Aza and Ven arm. What are my observations from this clinical trial? To certain extent, it feels we compare apples to oranges when we're talking about intensive chemotherapy and Aza and Ven, because we're using event-free survival as a measurement of success. Keep in mind that when you do intensive chemotherapy, it only takes 1 cycle, maximal 2 cycles, to declare that the patient was refractory to the disease. But it could take up to 4 cycles of azacitidine to go to the same endpoint. So even those patients that were refractory took 4 months on average to say they were refractory. So the EFS was longer because of that. And there was no overall survival benefit, at least in the last update. But even after all this analysis, I asked myself the question, do we really need azacitidine and venetoclax to be superior to intensive chemotherapy, or being non-inferior is enough to be the new standard of care? Because this could potentially represent how we start transitioning patients over 60 from the hospital stay to get a complete treatment at home with their loved ones. And this is my closing statement. A chain is as strong as the weakest link, and this is the importance of comprehensive approach. Sometimes we think that treating AML is just choosing the right induction chemotherapy, but actually it's much more than that. It's access to medicine for our patients, it's financial toxicity, chemotherapy toxicity, the patient's age. There are so many factors to come to that. And it really takes a big team to get these results done. So that's why I urge all of us here in this room to keep working as a team and keep moving the needle for our patients. And that's it for me. Thank you.